I love this meeting as well. Dr. Galgano was saying how he had saved all these when he was in training and learned from them. And I do too, not just spine oncology, which is my main interest, but I really enjoy all of them because I think learning from the different specialties who are treating our patients helps us understand each other better, communicate better, and then that ultimately ends up in patient care optimization. So since 2024, all right, so you can see my slides, right? And my mouse. Yes?
Yes.
Good, okay. So I think a lot of people here already know what SINS is. I always kind of struggle a little bit knowing how much detail to go into. But I think it's useful just to tell you my perspective on it. And I want to tell you a very fast story because it informs everything I'm going to say from here on out. I did a 2-year neuroradiology fellowship at Barrow, and then I went to my first job at USC. And I asked my boss, I was the first new person in 10 years. And I said, what can I do to really have my own niche and, fit in and do something good? And he said, well, you need a tumor board. And how about spine oncology? That's the hardest and the busiest. And I'm like, it can turn down a challenge. So I said, okay, sure. And I went with him and I watched and I'm like, oh my gosh, this is a new world. And I thought I need to read everything I can, learn everything I can from the spine surgery perspective, radiation oncology. And then I can really do a good job and take over and make a contribution. So when I did that and I started putting things in my reports about the SINS score, my colleagues would ask me, what is that? And I just assumed everybody knew except me. And then I found out that wasn't the case at all. Nobody actually in radiology knew about this at the time, 7, 8, 9 years ago. And I had the chance to give this talk at one of our big radiology meetings. And it was well received, not because of me, but because radiologists saw that there was something they could do to be very valuable to the team, to be valuable to the patients. And I kind of made it a little bit easy for them, which was even better. And I like to tell that story because a lot of times, there's some disconnect between specialties and they say, oh, why don't they give me what I want? And I like to tell my surgeons it's because we don't know. And so when we come to these meetings and we learn from each other, then we do know. And we can take all this information back to our people and work better together. So when I learned about SINS, that was in the setting of a tumor board. But to me, tumor board is one thing, but my real world was something else. This is a case that I like to show at the beginning. This is a 56-year-old woman who came into a busy county ER middle of the night. She didn't speak English. There wasn't much of a history except pain. And my fellow said, do I need to go down there or, do I need to call, see what else? And I said, no, there's only one thing this can be, and that's osseous metastatic disease. So this is our typical study, and you all know a lot about the imaging already, but if there's anybody watching that needs to know a little bit more about the imaging, sagittal T1, we have T1 hypointense vertebral body here, completely infiltrated by tumor, pathologic fracture, retropulsion into the canal. Sagittal T2 kind of shows us how it's compressing the thecal sac. Sagittal stir or fat saturated T2 takes out that bright marrow signal so you can really highlight edema and tumor cells. And then this is our post-contrast. I'm going to minimize my picture there. Post-contrast fat saturated image. So really what's highlighted again, taking out the marrow fat is real enhancement. It doesn't look like much there, but it really was. This is the axil of that, and you can see epidural tumor, pre and paravertebral tumor. So my fellow wrote this report, 2 pages of findings and everything. I said, oh, that's great. But, and this was his impression, suspected metastasis, pathologic fracture of L1, retropulsion, moderate compression of the conus, and that's fine, additional lesions. And I said, thank you for doing that, but I'm actually going to throw it away. This is my report. My findings actually were like 2 sentences. It was mostly impression. Unstable spine, SINS score of 13. Recommend prompt spine surgery consultation. And, it doesn't matter whether it's the ER doc, whether it's the intern, whether it's the medical student. They know the urgency of this and what they need to do about it. Next one, metastasis L1, pathologic fracture with retropulsion, greater than 50% height loss. All these phrases are components of that SINS score. And then number 3, high-grade conus compression, epidural spinal cord compression, or Bilski grade 2. Again, the ER doc might not have known, may not still know what this means. The intern doesn't know, medical student doesn't know. But when they would call, for our case, it was neurosurgery, they call up to the neurosurgery resident and say, the radiologist thinks you need to come see this cancer patient. I don't know why, but, they don't look terrible, but come see them. They look at my impression and very quickly they can see why I think they need to be consulted. And they don't even need to pull up the images, because immediately if they know the SIN score, they know in their heads exactly what they're going to be dealing with. Now, this was an interesting thing that happened at Spine Summit in Miami. I guess it was a year ago. This was not the original intention of the SIN score. And I think it might have been, maybe somebody in this audience or one of our speakers, or maybe it was Dan Schuba, said, do you think this is a problem, any kind of liability, anything like, why are you reporting this out of the ER? And I said, these patients, especially where we were, busy county ER, patient that's in an underserved population, once they leave, they're not coming back. So I want to err on the side of getting this person seen by spine surgery before they leave, and we never see them again, and their spine fails and they get paralyzed. So for me, this was the way I shaped it to the radiology audience, which, I was the first person to talk about it really, and kind of this is my most popular talk right before COVID. They asked me to speak about this all over the world. So kind of what I was saying about this, now everybody knows, but at the time, that's kind of the way it's evolved. So I think this is the way you all think about it now too. And I think, Mike Galgano gets his vets through the ER. I think he would agree with this as well. This is something important to think about at any stage. So my job, my perspective on SINs is that I want to rapidly triage a patient with an unstable or potentially unstable spine to surgical consultation. Now, that was an ER case. This was an outpatient case, breast cancer, a woman with known meds, but she suddenly, had acute pain and loss of function with this pathologic fracture, epidural extension of disease compressing her thoracic cord. And so it works for this too. We report these quickly, some places we do. And so we were able to call, get this person worked up, get them decompressed, and they regain their function in time. So again, this kind of communication and structured communication, I think, is very valuable, because in an urgent care, if you call the primary care doctor, if you call the oncologist, they might not know that in this case, this one's obvious, but they might not know this might be something that needs to have their instability addressed before their cancer is addressed. So when I presented it to my people, this is how I did it. I made this colorful diagram because I like it. And I said, you've got 6 questions, and you don't get to give prose answers. You don't get to give long answers to them. You get multiple choice. You use one of these answers and you can assign points. This is from the spine surgery literature, and we can give it a score, at least part of a score. Oftentimes we don't know pain. And so we say, this is our score without the pain element, and whoever, surgery sees them, they can figure that part out. And we give a recommendation. So these are some images. Again, you might all know the SIN score, but these are just some nice pictures that I like, and this is how I explain it. So these are the parts that are important. Question number 1, where in the spine is it? Not all parts are created equal. So junctional level, so where the calcareum attaches to the cervical spine, cervicothoracic, thoracolumbar. These areas, junctional levels, get a higher number of points, are more impactful when the spine fails than something like the rigid sacrum. So this is renal cell carcinoma on this axial CTA, destroying the posterior elements, encasing the vertebral artery. You can see there's not much holding the head on to the spine. Much more impactful for that person than this melanoma metastasis on this axial T1 weighted MR, where it's involving the whole sacral ala, probably in, compressing that S1 nerve. Here's this on CT, again, tumor going into the foramen. But when that fails, that's not going to cause paralysis, not paralysis or death. So different number of points. Lesion and bone quality. We know that lytic has a greater risk of pathologic fracture and rapid decline than blastic metastasis, both because of the lack of mineralization and the increased pressurization, just the nature of the kind of the biomechanics of that kind of process going on in the vertebral body. And you all know much more about this than I do even. This is a typical renal cell on this coronal CT, punched out lytic lesions, large soft tissue component. This is a nice path picture. So lytic gets a higher score than mixed or blastic. This is typical prostate cancer, blastic metastases. So coronal CT, sclerotic metastases throughout. This is a sagittal T1, sagittal T2. These are hypointense because they are blastic. They're kind of like rocks. They don't have a lot of mobile protons to give back signal for MRI. They can be non-enhancing. So sometimes they're hard and you need nuclear medicine to identify where they are. This is another nice path picture. This one I like showing people, lytic versus blastic. What would you call this? Because I defy anybody to see any kind of lesion here. But he did have pain, and he did go on to MRI, and indeed he did have a lesion. So big lesion, near complete infiltration of the body here. It's T1 hypointense, stir hyperintense, and enhancing. And here on this axial post-contrast, fat saturated image, you can see the large paravertebral, a little bit of epidural tumor. So we gave this a 1 for mixed because it's kind of the osteoclast and blast fighting for this one. We assess alignment and the percent of involvement of the vertebral body, the amount of collapse. So alignment, is there already subluxation translations already kind of unstable? Highest number of points is 4. New kyphosis or scoliosis. This was another breast cancer patient who had this fracture. It's compressing, but it caused her this new kyphosis that gets her a 2. And then, or normal, gets you 0. The amount of vertebral body involvement, is there already 50% collapse, or maybe no collapse, but more than 50% of the body is involved? So that, and that one's going to collapse soon. That one's going to, collapse. It's going to compress the cord, pain, paralysis, death. Involvement of the posterior elements. Is it bilateral, as in this case? This one, I think, was colon cancer. I'm trying to remember. So both posterior elements. Or in the thoracic spine, costovertebral joints, because in the thoracic spine, the ribs and the sternum give extra stability to the spine. Whole spine won't fail as quickly, thoracic, where it's got that stabilization, as in the lumbar or cervical. So this was another outpatient case. We'll do the SIN score on this one. This was a woman who was actually getting her MRI. She had I'm not showing the x-ray, but it was read as normal. She had a new radiculopathy, 40-year-old woman, no history of anything. And she had this left-sided radiculopathy, and this was pain management who ordered this MRI before they did some steroid injections. Well, this was a surprise to everyone. So we have on the sagittal T1 hypointense. It was enhancing. This is a contrast enhanced CT, so that makes it a little trickier because you can't exactly assess signal characteristics, but it was somewhat dense. So nothing else this could be except cancer. And it ended up being, I think, lung cancer. But we read this so quickly, I was able to call the pain management doctor. And I said, I just saw your patient. I know this is going to be an unexpected finding, but I gave you a SIN score in the report. And this is what this means in case you don't know. And indeed, he didn't. So it's at, this is a transitional anatomy case, but L5 is at a junctional level, which gave 3 points. It was mixed. I said it was sclerotic. Really, on the x-ray, you couldn't tell. So we gave it mixed. We gave it 1. The alignment is still okay, so no points for that. There's no collapse, but there is greater than 50% involvement of the body. There was only 1 pedicle involved, 1 posterior element involved, so I got it 1. And then I knew she had severe mechanical back pain because that was the whole reason for the study before she went to get steroid injections. So I could give her a SIN score of 9, and that was indeterminate. I told him, you probably want to work her up at this time. We didn't know what cancer it was. Work her up, bring her back in, and he ran out to the parking lot. They got her and brought her back in. And so they could find her cancer. I said, just let's find surgery no sooner rather than later. It's indeterminate, but, something to think about for the future. So in addition to that, we can also provide information on the degree of epidural tumors. So when, spine oncology, cancer, pain, paralysis, death can be from pathologic fracture from the osseous column, or it could be epidural extension of disease with cord compression. So epidural spinal cord compression scale. And I show our people this. And I say, what would you call this? And you know this from experience when you read your reports. They call it, I said, what do you call it? Do you call it cord compression? Do you call it canal stenosis? Do you say it's mild, moderate, severe? And nobody really has a good answer. And I would say even in anybody's individual practice, you're going to get 5 different answers from people. So here's a sagittal. This was a renal cell. So T1 hypointense, it's enhancing, and it's T2 hyperintense. And again, I show them these. I'm like, okay, so look at this set of cases. What would you call this one? Mild cord compression. What about this one? This was unusual. This was this is a breast angiosarcoma met. It was very strange on this myelogram, compressing the thecal sac from those sides. This was myeloma, and this I think was also angiosarcoma at the bottom. And so I asked people, think about how you're going to do this. If you use the epidural spinal cord compression scale, the Bilski scale, we can at least all be saying the same thing. And I show them this little thing that I made. I use this forever because I loved it. I was so proud of my little graphic. It's the best artist I can be right here. But low grade versus high grade, coming out of the vertebral body, compressing the cord, no CSF, grade 3, little CSF, grade 2, otherwise confined to bone grade 0 or grade 1 in the epidural space, but not compressing the cord. Axial T2 weighted images at the level of greatest compression is what I tell them to report. And I tell them why. And I tell them, it might require separation surgery. And that's something I've already learned in this meeting today is that, even when I learned this stuff, things have changed so much. And now I have to kind of revise what I tell them might happen based on what they say. With the newer techniques, it's always evolving. So this is how I made it easy for them. So in our reporting system, I was able to create this template where all they have to do is click on this. They can say, well, I don't know if it's supposed to say brand names or whatever, but show whatever our power system, our dictation system is, and they'd say macro SINs, and it would bring this up. All they have to do is click on these. So the level, the location, it gives them the options. So they don't have to look up the paper. They don't have to memorize it, although it's pretty easy to memorize when you do a lot of them. They click on that and it fills in the report. So you can do all the aspects of the SIN score with this. And you can even, gives you even your choices for recommendations and for severity, what you think it is for stability. So this was something we started 6-7 years ago for our American Society of Neuroradiology. And now it's moved into, it was kind of the first templates like this. Now they have them for all body parts. And it's part of our larger RSNA, Radiologic Society of North America, RAD Element project. And RSNA is kind of one of the biggest medical organizations in the world and the biggest medical meeting. So this is very impactful, I think, for everyone. It's taken a long time to get it going, get it agreed upon, and get it, kind of such that people can use it. But we fight on because we know it's important. So this is what my report would look like. So you can have pros, which all radiologists want, but I can have this in the middle, these macros where they fill in what maybe for a tumor board, maybe for the spine surgeon, oncologist, whoever, they can just go to this part and see exactly the parts they care about and know, why I graded it the way I did. I believe that is very important in addition to us all using the same language, because you also probably have this experience that you'll see one pathology and every radiologist calls it something different, which I think is unacceptable and we need to change. So I won't go into that. That's another talk for another day. But Mike Delgado said I was going to talk about frailty. I actually took it out because I thought he was going to talk about sarcopenia and frailty. But I'll just say a little bit about it. So bone quality. This is something that is fantastic from our Johns Hopkins friends who came out with this bone quality score. The physics of the MRI doesn't quite work on 1.5 versus 3 Tesla, but that's okay because all of it correlates. You see articles about this all the time, how useful this is. We don't personally use it because, well, I guess, I don't know. That's another story too. But this is something that I think is also useful. So automated opportunistic screening for osteoporosis, bone mineral density. This can also work for both osteoporosis, which last year we talked about a little bit at the end of this meeting, as well as cancer. And I'll show you that in a minute. So automated, fully AI kind of coming in, reading these in the background on all of our thoracic and abdominal CTs. Well, this information usually not used, which can be captured and put into reports and the patient's charts. And this has all been done by mostly by our friends at Wisconsin, but now it's kind of everywhere. It's been well validated what your bone mineralization should be at different ages at this level. And it's been incorporated into AI algorithms, which, like I said, can run in the background. Great, great tool. This is another thing that's coming in the future. I showed you that vertebral bone quality score from Hopkins. This is actually even more precise because this is something I've been trying to work on. Every pixel, it's not a pixel for MRI, but every voxel basically has a number associated with it, and it can differentiate tissues in the entire spine. So it can really tell you whatever is imaged here, what are basically numbers for the bone, for the cord, for the CSF. Amazing potential to tell us about bone quality on our standard MRIs. This can be run with any other MRI. And I don't think I have too much time for that, but this is also something I'm interested in. We can also evaluate, this is a post SRS tumor, and we can evaluate kind of the characteristics of that pre and post, if you can imagine radiotherapy, and kind of assess for that. Maybe we'll be able to tell where there's viable tumor without perfusion, which is hard to do without biopsy. Although I love biopsies, I don't think they'll ever be replaced. All right, so just one quick thing on frailty, and this is the same paper that Dr. Galgani used from our friends at MGH and Dr. Belsky. So John Shanell and Assad, great paper, the biomarkers for frailty. And frailty and sarcopenia are not the same. I think frailty is going to be a little bit more information that's going to be helpful. This is what has been done in a lot of the radiology literature and in other specialties as well besides surgery. So we are looking, this is kind of Perry Pickard, amazing body radiologist out of Wisconsin, has done this. And this also is automated, looking at, and you heard about this before, visceral fat, we have bone quality, we can get aortic calcium, muscle, all these things can give us kind of, they're surrogates for sarcopenia and frailty. So we can do risk assessment, we can assess what we think treatment efficacy is going to be from immunotherapy. We can talk about surgery. We can talk about a lot of different things. And this was a great paper. This was for colorectal cancer meds. And these 3 patients had kind of different profiles in terms of their fat distribution, the aortic calcium, and their muscle. And they all it correlated with outcome, basically, what their score was, how they did with their treatment and their survival. So really exciting stuff. And again, all this is not me measuring, in the reading room of my Hounsfield units. This is all automated AI. This is out there now. It's just a matter of making it easy and taking the information from it, getting it into the chart, getting it to our surgeons or whoever's treating the patients. Now, reporting, as much as I talked last time about like advanced imaging, it always came back to reporting. All the questions are always about that because that's the biggest thing that you all see from us. And again, this is what I just showed you. This is what I've been pushing for years and will continue to do, getting the information that you need. And that's where these meetings are important. I learned from you what we need to put in our reports. So it's much easier for you to get this. Having standardized content, having the same language, same terms for the same pathology, all radiologists. This is my fight. I think this is what the future of radiology should be and what's going to get us all better care and better communication. It also allows for downstream processes when it can be automated. So this is what I showed you with the macros. This is where we're going. We're saying this is kind of what I'm a part of. We're mining, we can mine the reports for data that can go into other things. It can go into registries, it can go into automated billing, it can go into automated like critical results that go out to the clinicians, get people into clinical trials. All this stuff is what we're working on, not a person doing it, but when we report it, it goes out automatically to these different things. And I think this will be super helpful for our patients and for our colleagues. Challenges are acceptance. Radiologists have to want to do this, and that's my job, is to try to sell it to them. And you all, like when Dr. Galgano and Dr. Shin, all of you come to our meetings, tell us that you really do need this. And that convinces people that we can do it and we'll make it easy. That's the only way forward, I think. It is hard when things change so quickly, our medical knowledge, our tools, our technologies, from you all, just again, hearing all the new stuff today that you're doing, I have to change my thinking, and getting that stuff quickly changed as it's going out is a hard part of this. And then dissemination, not just, among the academic centers, but all over the community, all over the world. How do we do that? So those are, that was very fast run through of kind of some of the things they're reporting, some of the things we can do that I think, in addition to SINs and getting SINs out there, might be helpful to you all in the future, looking at other measures that might help predicting outcomes for your patients, and how we can get all this stuff into all the other, clinical trials, all these other things that can help us in the future. And that's it. I talked really fast.
Thank you, Wendy, for that talk. Just a quick question we had was, can you talk a little bit more about advanced imaging in terms of perfusions? I know we briefly saw some things related to that.
So I think last time I had perfusion, and again, I was like, I have all this advanced imaging stuff, and then all the questions came down to reporting, so I took some of that stuff out. Perfusion. So perfusion has been around a long time. My friend Andre Haloni was the one who popularized that, maybe, I know for us, 10 years ago, First Spine Meds. It has not caught on. And some of the big places do it, but not a ton. And that's a problem, because it is, every tumor type is different, what your perfusion results will be. It's kind of a hard thing to run. It's a hard protocol for places to set up. So you're never going to have that in a community center. Even academic centers have a hard time with it. And a lot of people just give up. Our site, we have the best, MR physicists at our Keller Center. And yet our volume is too high. They cannot run that on everybody or even on the cancer patients. So it might be a good tool, but I think things like quantitative MRI, which I showed you, that can be run in our standard sequences in 5 minutes. I think that's the future, and that's kind of what I'm aiming for. So it's like perfusion, but better. So I hope that company now pays me.
So awesome and so great to see. So I'm going to take a snapshot of the screen. So many great minds on this one screen together. Dr. Gokazlan, Dr. Bilski, and the others. So, Dr. Gibbs, you've done some magical things. I mentioned it last year. I don't know how and what you did. Is this you or is this the radiology world that's kind of seeing that we need to work in a more interdisciplinary fashion to get our way of categorizing and quantifying disease into your world? I mean, I see this more and more now, finally, and there's so much more to do. We finally now have our radiologists read out the sagittal and coronal parameters for deformities as routine for our scoliosis homes now. So was this your initiative, the center's initiative, or was this a systematic effort to finally kind of cross-pollinate?
You know, as much as I would like to take credit for it, I think that the newer generation of radiologists realize how important it is. And our new tools, you know, a lot of our new tools make that easier for us to do those things. But it also is dissemination like this, giving talks at different meetings. Like, again, like I said, you know, I was one of the first people in our societies to have some of the surgeons, a lot of surgeons come talk at our neuroradiology meetings and our spine radiology meetings. And hearing from our spine surgeons is huge. They, you know, the radiologists might listen to me a little bit, but they listen to Mike Delgado. They'll listen to John Chin. You know, they listen to these people who are coming to really tell us what is important and why. And then, like I said, you know, I get to hear you all and you know, I learn what you all think is important. And I take it back and say, oh, you know, this is what Zia said. This is Dr. Bilski said, you know, so those things, I think that kind of cooperation and just hearing those things in our talks, in our papers, that all of that I think has contributed. And I think there's just a lot more, like I said, a lot more tools with AI now being more developed, a lot more things we can do that disseminate things and make things a little bit easier. So that's it.
And there's so many things to talk about with you, but I really appreciate this call out for the untapped use of bone health and kind of moving beyond DEXA scans, which are frequently false and negative, and using far more dynamic either Hounsfield units or maybe quantitative MRI. How reasonable and how much of a surcharge would be quantitative MRI scan?
Well, so again, I don't want to say I don't want to do anything against CME here. There is there's a company that does that. I've been doing research with them, but more and more different vendors, the MRI vendors, can do this. It's still in development, so it is something that needs to be actively researched, you know, quantified. It theoretically it works, you know, it works as well as perfusion, and it'd be faster. For the opportunistic screening, that is huge right now, and we just I think one of the AI companies that does that opportunistic screening for bone mineral density for osteoporosis, they just got their you can get reimbursed for it now, basically. One of the first companies that has that now, which is huge for population health. So that's one of my, you know, my big passions too, is osteoporosis, because so few people get DEXA. So few people get DEXA, and this can be huge because everybody will get it running in the background. It'll go into the EMR, it'll be in their chart, that number, you know, without anybody having to measure anything or even knowing they need it. So it looks like
so many more things to ask you. Maybe we can communicate that offline,
sure,
because we've worked a lot in infections, and I'd love to hear from you more about SINS and ESCC versus infections and osteodiscitis. We in Seattle are bombarded by this, just like we're from tumors, and we do need some help in that arena to, I think, quantify things better. So we want to thank you. Just, I mean, again, the questions could go on for hours. But thank you for cross-pollinating. Thanks for sharing, and really cool stuff. The drop-down menu, please make it available tomorrow. I mean, your graphics are great. I'll have our radiologist weigh in on that also, but thank you.
Thank you so much. Thank you.
Again, the hits keep on coming.